Hello, this is a video on the NG tube insertion and removal. So first, this is my patient, Miss Jones. First, I'm going to introduce myself to her. Hello, Miss Jones, I'm Brenda Lynn. I'm going to be a student nurse. I would do 2 patient identifiers. She would also have a wristband on, so I'd be looking at that as she told me her name and her birthday. I would verify the doctor's orders and make sure that I have the right equipment. Today, we're going to do a saline slump. I guess that's a large nasogastric tube. This one can be used for feeding medication, also gastric decompression, all that good stuff. It's a multi-use NG tube. So before I start, I'm going to ask her if she has any medical history involving her nose, like any nose problems, so like nosebleeds, or if she had any oral, facial, or sinus surgery. I'll also assess for aspiration, if she has nasal polyps, and if she's taking anticoagulant medication like Coumadin. So I'm going to provide privacy now, and I'm going to, these are all my supplies. I'm going to perform hand hygiene, and I'm going to inform Ms. Jones what we're doing and why we're doing it. So I would tell her she needs an NG tube for feeding and medication. I'm also going to answer any questions she has, and I will obtain verbal consent before I proceed with the procedure. After she says it's okay, I'm going to assess to see if she has any pain, nausea, or vomiting. And when she doesn't, I'm going to go ahead and raise the bed to a comfortable working height, hip level, and I will place Ms. Jones in a high Fowler position. I'm going to go ahead and perform hand hygiene, and I have some tape. There it is. This one's better. I had some over here, but I have a feeling that this one would be better. My fancy pants. Okay, so now that I have my tape ready, I'm going to go ahead and don on my gloves. So after my gloves are on, I'm going to assess the nasal passages with a pen light. So I've got my handy dandy thing. I'm going to look up Miss Jones's nose, and I'm going to see if there's any obstruction, nasal polyps, if there's any irritation to the mucosal lining, or if she has a septal deviation or defect. I'm going to confirm with the patient that she hasn't had any recent nosebleeds, nasal trauma, or surgery, and I will assess the patency of her nose or her nostrils, whatever. So I'll have her breathe in and out, and then I'll test the other one, breathe in and out, and I will decide from there which one I want to do. So I'm going to go ahead and do the one on her right side. And then I'm going to go ahead and assess for gag reflex. I'll either have her have a drink, like a test if she can swallow, or I will use a tongue depressor to touch the back of the tongue and see if that initiates a gag response. I'm then going to go ahead and auscultate for lung sounds and bowel sounds. Do a quick little thing. So I will do lung sounds. And so on, and then I'll go ahead and listen to her bowel sounds. And so on. So everything sounds good. Now I am going to start going ahead with my insertion. I'm going to test the length of my tubing first, and you're going to test it, start at the tip of the nose to the earlobe, and then from the earlobe to the xiphoid process. So I'll just measure it on myself. So here, to here, and then right here, and then maybe a bit more. So that is at right there. Let me lay this out first. I have a piece of tape, and I'm going to go ahead and mark. Okay. So now that that is measured, I will, what am I doing? I will lubricate the tubing about 4 inches up the tube with a water-based lubricant. I don't have any, so we'll do that. I'm then going to, I already placed a towel on my patient's chest. I also have, this is my emesis basin. I would also give that to her. Also some tissues if she needs it, and I will give her, let's say water. Right, I will give her a cup of water, a water with a straw in reach. I'm going to go ahead and start inserting the tube. I'm going to aim to the back of, towards the patient's ear, back and down towards the patient's ear. And once I hit the nasopharynx area, I will then have the patient tilt their head forward to their chest. So Ms. Jones, I'm going to insert the NG tube. Just bear with me, this may cause a little discomfort. And I'll go in. And I've got resistance. So I'm going to have her take a few drinks and have her tilt her head forward. And with each drink, when she swallows, I will advance the tube. So swallowing. And I will advance until it meets the tape where we measured earlier. Okay. So you always want to make sure you have the tubing in your hand. You don't want to let go and have it cause discomfort. So I am going to hold the tube in place with some tape. Excuse me, sorry. Okay. And this is anchored. I want to go ahead and kind of tape it over here just in case. Get it out of my way. Don't mean to put it in your eye, Miss Jones. Okay. Now that I've had that in a secure place, I'm going to check the back of the throat to see if the tubing has made it down the esophagus or if it is sitting curled up in the mouth. So, and I see it down there, so we're good to go. No curled up. Now I'm going to go ahead and auscultate for lung sounds. As I can see, I don't hear her coughing, and she's showing no signs of respiratory distress. I'm going to go ahead and listen to her lungs. All right, and so on, everything sounds good. At this time, I would have a syringe, and I would test to see if we are in the right place by giving a little gastric aspirin and then measuring the pH on one of the pH papers, and it should be in between a 0 and a 4. If it was higher, like in a 6, it would be possibly in the respiratory area or in the small intestines, so that wouldn't be good. You would want to take that out. Once you find that the pH is in the right level, you're going to get a chest x-ray to further confirm placement. And it's depending on what you're supposed to do on the facility's policy. You're either going to put back that gastric acid or that gastric content, or you will dispose of it. And then I will fasten the tube to the gown once it is, all set and ready, and I will clamp the tubes with the connectors. All right. I will then keep the head of bed at a 30-degree angle. So yeah, I think that's it for that one.